For decades, the academic model of addiction has focused on the mesolimbic dopamine system. During the initial binge and intoxication stage, drugs trigger a massive surge of dopamine, chemically reinforcing the behavior and creating a powerful sense of reward. Over time, the brain undergoes neuroadaptation to counteract this influx. The original euphoric response to the drug physically blunts as the circuit builds tolerance. This creates a paradox in addiction research. If the euphoric high disappears, what biological mechanism drives a patient toward compulsive, life-destroying drug-seeking behavior? To find the answer, we must look past positive reinforcement and focus on the withdrawal and negative affect stage of the addiction cycle. This stage is marked by two distinct clinical consequences. The first is hyperalgesia. Hyperalgesia is a severe hypersensitivity to physical pain, where normally harmless stimuli become agonizing. The second clinical consequence is hyperkataphia. Hyperkataphia is a hypernegative emotional state characterized by severe dysphoria, anxiety, and intense psychological irritability. Late-stage drug seeking is the product of negative reinforcement. Compulsion is driven by the immediate requirement to suppress the agony caused by these conditions. The primary biological engine driving this misery is the anti-reward network, governed by the endogenous dynorphin and kappa opioid receptor, or KOR, system. In this model, addiction is a disorder of extreme suffering, maintained by an internal system that biochemically punishes abstinence. To understand the specific punishment, we must establish exactly how the brain's endogenous opioid system regulates both pain and mood. The most recognized component is the mu-opioid receptor, or MOR. Activation of the MOR, whether by natural endorphins or drugs like heroin, reliably produces analgesia and euphoria. The kappa opioid receptor, or KOR, functions as the direct antagonist to the MOR. Its activation produces an entirely opposing biological response. The specific endogenous ligand that naturally binds to the KOR is a peptide called dynorphin. KORs are GI-coupled receptors. A GI-coupled receptor acts as a biological brake, actively inhibiting cell excitability and suppressing the release of other neurotransmitters. When activated by dynorphin, the KOR directly produces states of dysphoria, physical aversion, and systemic stress. The human brain contains a dedicated system designed to manufacture misery. Chronic drug use weaponizes this system, making stress the baseline biological state. This adaptation begins in the nucleus accumbens, or NAC, the traditional center of reward processing. Repeated drug exposure forces the NAC to undergo within-system neuroadaptations. Within-system neuroadaptations are structural changes a circuit makes to itself to counteract excessive chemical influx. As a defense mechanism, the brain triggers a massive upregulation of prodynorphin, the precursor to dynorphin, directly within the nucleus accumbens. This synthesized dynorphin binds directly to kappa opioid receptors located on the terminals of dopaminergic neurons. Electrophysiologically, this KOR activation forces a severe reduction in dopamine transmission. The receptors physically throttle the release of dopamine into the synapse. This suppression creates a persistent deficit in reward sensitivity. Without baseline dopamine flow, normal life experiences become joyless. The brain actively suffocates its own reward signal in a destructive attempt to maintain neurochemical balance. The pathology then expands beyond the reward center and into the extended amygdala. This specifically involves the central nucleus of the amygdala, or CEA, and the bed nucleus of the stria terminalis, or BNST. Both are primary nodes for processing fear and stress.
This expansion is driven by between-system neuroadaptations. Between-system neuroadaptations occur when the failing reward circuit recruits distinct external stress and fear circuits. The biological trigger for this takeover is acute withdrawal. Clinical evidence of this systemic shock is visible in precipitated withdrawal, often triggered by an opioid antagonist like naloxone. Withdrawal causes an immediate spike in FOS and ZIF268 inside the CEA. FOS and ZIF268 are immediate early genes, which researchers use as primary markers to map recent neural activation. During this spike, corticotropin releasing factor, or CRF, promotes a flood of dynorphin within the CEA. CRF is a peptide hormone that initiates the body's physiological stress response. This dynorphin flood modulates the release of GABA. GABA is the gamma-aminobutyric acid neurotransmitter responsible for maintaining the inhibitory calming balance of the amygdala. By disrupting the amygdala's balance, the dynorphin surge generates the physical experience of hypercataphia. The result is overwhelming anxiety and emotional pain. Withdrawal is an active, aggressive neurochemical assault launched by the extended amygdala. While the amygdala drives emotional pain, the withdrawal process also manifests physically as clinical hyperalgesia. The interface for this pain is the periaqueductal gray, or PAG, and the spinal cord. The PAG is a brainstem region critical for modulating descending pain signals. Chronic opioid use triggers an abnormal upregulation of dynorphin within the spinal cord. This upregulation shifts KOR signaling toward a highly pronociceptive, NMDA-dependent mechanism. Pronociceptive means it actively amplifies pain signals, while NMDA refers to the specific receptors mediating that transmission. The KOR system begins actively generating pain rather than suppressing it. This explains why patients in methadone maintenance therapy show significantly lower pain tolerance during cold pressor tests. Their baseline sensitivity to physical pain has been biologically heightened. These combined mechanisms are part of a framework called the allostatic shift. Allostasis is the process by which the body maintains stability through physiological change. In severe addiction, the brain abandons its original baseline. It settles at a new pathological baseline dominated by KOR and dynorphin. This chart shows the mechanical reality of the allostatic shift. On the left, drug intake volume escalates over time. On the right, we see the correlated growth in KOR and dynorphin density in the extended amygdala. The relentless escalation of drug intake is a mathematical necessity to suppress surging KOR pain signals. Mapping this architecture provides a clear pharmacological target for treating opioid use disorder. KOR antagonists are a primary therapeutic target for severe SUDs. Researchers are investigating compounds like norbinoltorphamine, a selective antagonist that blocks the kappa opioid receptor from being activated. Preclinical evidence shows that KOR antagonists block naloxone-induced conditioned place aversion, preventing animal subjects from associating a location with the misery of withdrawal. Furthermore, systemic infusions of these antagonists successfully reverse withdrawal-induced hyperalgesia, returning pain sensitivity to normal levels. By blocking the KOR system, these compounds neutralize the motivational root of relapse by eliminating the misery of withdrawal. Medicine must look beyond the dopamine systems that initiate drug use. Long-term recovery depends on addressing the dynorphin and KOR systems that punish abstinence. Treating addiction requires repairing a broken anti-reward system to allow patients to finally escape hypercataphia.